Hi, guys. I know I didn't tell you where I would put the review session, but I put it in with RET 2265, the Advanced Equipment Lecture. So that's where I'll be putting it from now on. But even though it's there, we can still review for all three classes, the neonatal class, advanced equipment, or the pulmonary function. So going through the recordings from lecture, please do that and don't let this review substitute for going through the lectures, because I might skip over something on the review that you need to know. So it's best if you also listen to the lectures. All right, so I'll start with neonatal lecture, and we talked about what to call a baby that's born. So if they are 2 years old, do we call them a neonate, an infant, or a pediatric? And the answer is, at that point, they're considered a pediatric. So from 1 year up to 16 years of age, it's a pediatric patient. What if they are born and it's their first week of life? What do we call them? And the answer is a neonate. After the first 30 days, now we refer to them as an infant. So I'll just put age of infant. Oh, nothing happened. Okay, then we talked about the placenta and the job that the placenta does in utero while the fetus is developing. So the placenta implants in the uterine wall. Mother's blood vessels grow into it, fetal blood vessels grow into it, and that's where the exchange of oxygen, carbon dioxide, nutrients take place. The blood vessels from the fetus travel from a branch off of the femoral artery, the internal iliac artery, go to the umbilical cord, from the umbilical cord into the placenta. And then there's two arteries that go to the placenta that take the deoxygenated blood from the fetal body and deliver it to the placenta. And then once the gas exchange takes place across the chorionic villi, then the blood returns via one vein back to the fetus. And we'll talk about fetal circulation on our next lecture. Okay, we talked about problems that can occur with the placenta. Since the placenta is providing the oxygen, the nutrients to the fetus, if something happens to the placenta, that's going to compromise nutrients and oxygen delivery to the fetus. So if it separates from the uterine wall, placenta abruptio is the Latin term for that. That's going to compromise the fetus. If there's a chance that the fetus is not getting enough oxygen and nutrients, they may induce labor or do a cesarean section and remove the fetus. We talked about the placenta planting too far down in the uterus and covers the cervix. And that becomes a problem because during delivery, the cervix is the birth canal. So the baby has to go through the cervix, through the birth canal in order to exit mom. So if the placenta implants there, now they'll have to do a C-section instead of a normal vaginal delivery. A couple terms that we talked about. What is IUGR? And the answer is intrauterine growth retardation. So if the fetus is not getting enough nutrients, enough oxygen, it's not going to grow, and its size will be smaller, and they won't be as developed as if they're getting enough nutrients and oxygen. And we talked about fetal asphyxia. So fetal asphyxia, anytime we talk about asphyxia, we're talking about the lack of oxygen. So lack of oxygen affects the brain the most. So you can have delivery, you can have lack of oxygen delivery. It is going to affect the brain the most. So it's really critical to get oxygen to the fetus. If a neonatal intensive care unit offers advanced life support, such as high frequency ventilation, jet ventilation, if they offer ECMO, if they have 24-hour-a-day surgeons, what level neonatal ICU is that? Is it level 1, level 2, or level 3? And the answer is that's a level 3 neonatal ICU. Okay, what is the normal PaO2 of a fetus? Spitzu. Normal PaO2 of a fetus is 32 millimeters mercury or 32 torr. So that's like a capillary, even lower than capillary oxygen. Capillary oxygen is usually 40 to 60, so that's even lower than capillary oxygen. That's like venous blood. And yet normal fetal development can occur in that level of PaO2. We talked about fetal hemoglobin and how fetal hemoglobin is different than adult hemoglobin. So with fetal hemoglobin, it does hang on to oxygen with a stronger affinity, causing a leftward shift of the oxyhemoglobin dissociation curve. Because it hangs on to oxygen more tightly, it's able to extract more from mom's blood, and it just helps with carrying more oxygen at that low PaO2. After birth, the fetal hemoglobin is no longer produced. It begins getting replaced by adult hemoglobin. So as the red blood cells age and are removed from the bloodstream and new blood cells are made, adult type red blood cell with adult type hemoglobin will exist. And it takes about 3 to 4 months for all of that fetal hemoglobin to be removed from the body. And then we talked about the different stages of fetal development and how the stages kind of overlap each other. So when I gave you the weeks of gestation, with gestation meaning the time since conception. So conception occurs, and during the first 8 weeks, the types of cells that are dividing are called embryonic cells, and it's the embryonic stage of development. And then after, during those first 8 weeks, there is a lung bud that branches off. The esophagus and the trachea become separated, and then we get like a right and left main stem bronchus, and that's it after 8 weeks. Pseudoglandular stage, when we start getting more of those conducting airways forming, and that's 7 to 17 weeks of gestation according to the textbook. And once we get into the next stage, the canalicular stage, now we get more branching of the conducting airways. The pulmonary vasculature starts branching and coming closer. Alveolar sacs. How formed are alveolar sacs in this stage? Yeah, our notes say the asinus develops. So we have the asinus. When I think of a sinus, I think of a bunch of grapes hanging on a stem, and all the grapes are the alveoli, and then the stem and the branching of the stems. That's like the alveolar, like an alveolar sac. So you have your alveolar ducts, your alveoli. The development of that is occurring, and by the end of this stage, around 26 weeks of age, the alveoli and the pulmonary vessels are close enough to each other where gas exchange could take place if the fetus is born prematurely. There are type 2 cells. The type 2 cells do have the lamellar bodies. However, the surfactant that's in there has not matured yet. So typically when a baby is born prematurely between 22 and 26 weeks of age, they need to have exogenous surfactant delivered to their lungs. So we'll talk about how that's done later on in a different lecture. But yeah, their surfactant hasn't developed yet. It's possible if the obstetrician can foresee that, there's no way that we're going to be able to stop labor, or the fetus is not developing normally, we need to have a delivery. So either labor is allowed to continue, or they do a C-section to take the fetus. And at that point, do they need to have, at that point, if they realize that delivery might happen, they give mom steroids. Giving mom corticosteroids will cause the surfactant to start maturing, so that by the time the baby's born, they may not need to have exogenous surfactant delivered. Okay, then we went into other stages like the saccular stage, where you get more development of the alveolar sacs and alveoli, and then the area for gas exchange between the pulmonary vessels or the capillaries and the alveoli, it thins out, and they get very close to each other. So then gas exchange, of course, becomes normal if the baby is born at that point. So here's a question for you. Okay, so I wrote a question on the whiteboard. So during fetal ultrasound, it is noticed that the fetal chest is moving in and out. Is the fetus breathing air? Is gas exchange occurring in utero? So when we see the chest moving in and out, does that mean that there's air coming into the lungs? And the answer is no. So there's no gas exchange taking place in the alveoli and the pulmonary vessels while the fetus is in utero. So while the fetus is in mom, the only way the fetus gets oxygen is from the mother's blood coming into the placenta. So that's the only place where the fetus gets its oxygen. The breathing movements of the chest help to develop muscles so that when they're born, they have good muscle development so they can breathe on their own. But there is no gas exchange occurring. Next question. So I wrote, is it true or false that conducting airways and alveoli are filled with fluid in a fetus? And the answer is true. So during delivery, all that fluid has to come out of the lungs, which it does, like during a vaginal birth, squeezing of the chest, going through the birth canal, gets rid of the fluid. The lymph system absorbs fluid, and now the conducting airways are filled with air. So after birth, they're filled with air, but before birth, they're filled with fluid. Then I asked you, how many alveoli does a newborn have? Do you remember the answer? 50 million. And how many alveoli does an adult have? And the answer is 300 million. Good. So the lungs are not completely developed like adult lungs when a baby is born, but it continues up to 8 years of life. And at 8 years of life, then the lungs are completely developed into adult lungs. Do you remember the purpose of surfactant and why surfactant has to be mature to help a newborn breathe? Like, would you be able to explain to me the purpose of surfactant and what it does? Okay, so what you would tell me is it's a fluid that's secreted into the alveoli, and the fluid helps to keep the alveoli open. Without surfactant, the alveoli collapse. And if the alveoli collapse, now air can't get in there, oxygen can't get in there. And what we'll see is the newborn will have difficulty breathing. Their oxygen saturation will be much lower than normal. And when alveoli collapse, it causes the lungs to be less compliant. So now their work of breathing is increased. So you see a lot of sternal retractions, intercostal retractions, because they're working really hard to breathe with these stiff lungs. So having a lack of surfactant, it leads to, it's called respiratory distress syndrome. We'll talk about that in a future lecture. More questions? How many weeks of gestation are considered a full-term birth? And the answer is more than 37 weeks of gestation. So from the time since conception to 37 or more weeks, when the baby is born, they're considered full-term. So they should be fully developed. They will be fully developed at that point in time. Difference between being born at 37 weeks and 40 weeks is that they gain weight and then their organs continue to mature. Can the organs and can they gain weight if they're born at 37 weeks and they're now born? Can they still gain weight? Can their organs still develop? Yes. They've got plenty of surfactant and they're good to go as far as their lungs go. So if I ask you, while the fetus is in utero, how can we assess the fetus? How do we know if it's alive? How do we know if it's in distress? And do you know what you would tell me? We would perform a biophysical profile. So this is using ultrasound. With ultrasound, they can measure the size of the fetus and compare that to what should be normal to determine if there's growth retardation occurring. If the fetus is moving around, that's healthy. If they have gross body movements, like they're moving their arms and their legs, that's a good sign. Their heart rate should be going up and down. When they move around, it should go up. When they're holding still, it should go down. If the heart rate stays at one level and never changes, that's not a good sign. What else do we have? Then they look at amniotic fluid volume. So a fetus is surrounded in a sterile liquid sac, and the amount of volume is important. So having too much volume can lead to brain damage. Too little volume, I can't think it affects the lungs. Oligohydramnios. Yeah, I just have down that it affects lung development. So not having enough amniotic fluid can affect lung development. All right, then let me pose a clinical question here. If a premature delivery is imminent, meaning like it's going to happen, they're not able to prevent it, what can be done to help mature the surfactant? Do you know the answer to that? Yes. So we can give mom steroids or glucocorticoids, and doing it up to 48 hours before delivery, then the surfactant will mature. And when the baby's born, we may not have to give them exogenous surfactant. We talked about tests performed on amniotic fluid. And when a sample of amniotic fluid is taken, then from that fluid, there's a lot of information that can be gathered. They can look for the sex. They can look for genetic defects such as cystic fibrosis, spina bifida, Down syndrome. They can look at lung maturity. They can measure the amount of lecithin and the amount of sphingomyelin and see if there's twice as much lecithin as sphingomyelin. So if the ratio is 2 to 1, then the lungs are mature. I didn't say that right. The surfactant is mature. The lamellar body test, I had you write that in because it wasn't in the PowerPoint. What level indicates lung maturity? And I didn't write it in my notes either. I think it was 50,000. And I don't have the units in my mind either. So I'm going to have to look that up myself. Lamellar body count. They can check for a phospholipid called phosphotidylglycerol. And it's considered very reliable if they find this phospholipid, because that indicates that the surfactant is mature. Another test is the shake test, where they mix alcohol with the amniotic fluid to see if bubbles form. And if bubbles form, then there is surfactant present. If there's not enough surfactant, you won't get bubbles. All right, and then we went into fetal heart rate. So when can you hear heart sounds? So what is the earliest gestation that you can hear heart sounds? And it's done via vaginal ultrasound. So going through the vagina and listening, I don't know what kind of a microphone they stick on the uterus, but that's how they can hear heart sounds. And the answer is 8 weeks of gestation. Oh, I have 7 weeks, sorry. I have 7 weeks in my notes. And again, it's normal for heart rate to vary in utero. All right, and then we talked about during labor, there's 2 belts placed around mom's abdomen. One of the belts will record when the uterus is contracting. So in order for a baby to be born, the fetus has to be expelled from mom. So what happens is the uterus starts contracting stronger and stronger until it finally pushes the fetus out. So during labor, looking at the uterine contractions and also keeping track of heart rate. If the uterus contracts and it squeezes the fetal head, that causes stimulation of the vagus nerve and the heart rate slows, but that's okay. What's not okay is if the uterus contracts and then after the contraction, heart rate falls. What that tells us is that the placenta was being compressed during the uterine contractions. And if the placenta is compressed, that's going to cut off blood flow to the fetus. So fetal heart rate is falling because they're hypoxic. They're becoming really low on oxygen when that happens. So that's not a good sign. They'll probably end up doing a C-section rather than waiting for mom to deliver normally, a normal vaginal delivery. And I think that was it for neonatal. All right, so I will clear this and then we'll move on to RET 2265. Okay, let me just switch my notes real quick. All right, so in advanced equipment lecture, we talked about modes of ventilation. We reviewed what you already had in your past mechanical ventilation lecture. We separate the modes into volume modes and pressure modes. The only 2 volume modes are volume control, is what the servo calls it, and then SIMV where you have mandated breaths and you can have spontaneous breaths also. So as AC, let me write it down. That's all I can come up with. So what's the correct response? So volume control can also be referred to as which of the following? Can you call volume control AC/VC? And the answer is yes. So when you use that kind of nomenclature, when you're putting two, it looks like you're putting two modes together. The first mode tells you whether it's full support, or it's a weaning mode, or it's a spontaneous mode. So that's the first letters. The second letter tells you what type of mandated breaths you're giving. So can you call volume control AC/VC? And the answer is yes. Can you call volume control assist control only? Like there's no other letters, anything, just assist control? And the answer is yes. So going back many years ago, that's all was available pretty much, was assist control where you deliver a specific volume. So assist control always meant volume control. Can you call volume control AC/PRVC? And the answer is no. So PRVC is a pressure control breath, and the pressures vary to target a tidal volume, so that does not constitute a volume mode of ventilation. So A is correct and B is correct. Okay, let me ask you another question. Let's see. If a patient initiates a breath, they're in AC/VC or volume control, they initiate a breath. Is that considered a spontaneous breath? So the answer is no. So what is it called? It's called an assisted breath. So that would be called an assisted breath. Let's see, what else can I ask? So for all of the modes of ventilation, you need to know what the physician orders. And then as a respiratory therapist, when you put those settings into the ventilator, what other settings are you setting? So you have to know that. And you also have to know what cycles of breath, what's limited. So let's review that. So the first one we have is AC/VC or volume control. How would we describe that mode of ventilation? So we would call what cycles it or what ends inspiration. It's when the volume is delivered. What is limited? Well, one of the disadvantages of this mode is we have to set the flow rate or the I time to give us the flow rate. And we want to give enough flow to meet the patient's needs, but we don't always give enough flow. So it's kind of like the disadvantage we talked about. But anyway, that's what's limited, flow limited. So volume control breath is volume cycled, flow limited. Okay, next. Describe SIMV. So with SIMV, we have two types of breaths. We have our mandated breath, and then we also have a spontaneous breath. So there's going to be two parts to describing this mode of ventilation. So we start off describing the volume control breath, the mandated breath, and it would be the same, volume cycled, flow limited. And then we describe the spontaneous breath. And spontaneous breaths, we always want to have pressure support set for our spontaneous breaths. Even having minimum like 5 centimeters water of pressure support, that's enough to overcome the resistance of the endotracheal tube, the resistance of breathing through the ventilator circuit. So when we say spontaneous, we want to say pressure support breaths. So how do we describe a pressure support breath? So it's pressure limited. And what causes the breath to end? It's when flow slows down or flow diminishes. So spontaneous breath is pressure limited, flow cycled. Okay, let's see, SIMVBC. And how do we describe pressure control mode? So what ends inspiration? What is limited? So in pressure control, we set an inspiratory pressure and it doesn't go above that inspiratory pressure. So what will happen is the volumes that are delivered will vary, because when you're only delivering a specific pressure, the amount of tidal volume will depend on airway resistance and lung compliance, size of the lungs. So volume is going to vary. The breath ends when the inspiratory time is up. So if you have a 1 second inspiratory time, after 1 second, the breath will end. It won't matter if the lungs have filled up with air or not. After 1 second, the breath ends and exhalation begins. Let's see, talked about volume control, SIMV, pressure control. And then we also talked about PRVC. So how do we describe PRVC? So those are pressure limited breaths, volume targeted, and time cycled. I don't think I said that in order. So we usually say pressure limited, time cycled, and volume targeted. So what does that mean? So it is a pressure control breath, The ventilator is going to decide how much inspiratory pressure is needed in order to deliver the tidal volume. And it may have to change the amount of pressure from one breath to the next, and it'll change it by 3 centimeters water at a time. It'll keep increasing all the way up to the high pressure limit, and it can decrease all the way down to 0 pressure. If the patient is breathing large, deep breaths on their own, it'll decrease the amount of pressure all the way down to 0. What's nice about this mode of ventilation is flow is variable. You get a lot of flow initially to reach that set inspiratory pressure, and then the flow slows down during inspiration so that pressure stays constant. So we get a decelerating flow. Okay, and then for I feel like we went through that. And then we worked on, what did we work on? Yeah, the notes are really good with giving you scenarios and questions. So maybe you can look at it without knowing the answer and figure it out in your mind, because that'll be a good review for you. We went through calculations. Let me give you a couple calculations. I'm almost done with my hour of recording. So I'll make it quick. Let me just give you 2 examples of calculations. I need to know what the calculations are. I think one was we had to figure out, okay, a patient's spontaneous tidal volume varies a lot. 300 one breath, 800 the next breath, 400 another breath, and we need to document their spontaneous tidal volume. So what can we do? And because typically all you do is look at the digital readout, get an average, and that's what you record. But we can also calculate that. So we need to know the spontaneous minute volume, the spontaneous respiratory rate, and then we divide that to get the spontaneous tidal volume. So our box comes in handy. How can I draw the box on here? It only allows me to draw one line. Oh, just great. Okay, that's not working out. Let's see, draw squigglies. Here we go. We had very vit, so minute volume, respiratory rate, and tidal volume. And then going down the side, we had too much sugar. So total, machine, and spontaneous. So for total minute volume, that has to be given to you. So patient's minute volume is 12 liters. They're breathing 32 times a minute. The ventilator is set at 500 ml and 10 breaths per minute. And from that information, we're going to figure out the patient's spontaneous tidal volume. So we're given the total minute volume of 12 liters. So 12 liters, good luck drawing a 2 with a mouse. The machine minute volume. Do you know how to figure out machine minute volume? You have to multiply the tidal volume times the set rate, and that's going to give you the machine minute volume. So it says here 500 mLs times 10 breaths a minute. So 500 times 10 is 5,000, but we want to put that in liters. I mean, you could do everything in mLs or everything in liters. Currently, I have 12 liters, so I'm going to stick with liters for now. So 500 times 10 is 5,000 or 5 liters. So all of the minute volume except 5 liters is the patient's. So in order to get the spontaneous minute volume, we take the total minute volume, subtract the machine minute volume, and then we come up with the patient's spontaneous minute volume. So 12 minus 5 is 7. So the patient is moving 7 liter minute volume on their own. And then we do the same thing with the respiratory rate. We take the total respiratory rate, subtract what the machine is set at, and the rest of it is the patient initiating or breathing spontaneously. So the total respiratory rate here, it's 32. So I put 32. These boxes we don't need. So the total respiratory rate is 32. The machine is set at 10. So 10 of those breaths are from the machine. And the rest of them are spontaneous breaths that the patient is breathing. So 32 minus 10 is 22. All right, so we now know the spontaneous minute volume and the spontaneous tidal volume. And we're going to divide those two to find out what the spontaneous, I didn't say something right. We know the spontaneous respiratory rate and the spontaneous minute volume. We have to divide those to get the patient's spontaneous tidal volume. So 7 liters divide by 22. It's out to 0.318 liters. 0.318. And that answer is in liters. So how do I take 0.318 liters and convert that to mLs? I move my decimal point 3 places to the right, and it comes out to 318 mLs. Whoops, that's my L. All right, and then the other calculation that you have to know is figuring out how many mLs per kilogram a patient is being ventilated with. So if they're on the ventilator and there's a tidal volume set, you have to figure out their ideal body weight. And I hope I remember to hand them to you. I finally got some measuring tapes to give to you guys. So you hold one at the top of the head, and one person stands there, so you have to have 2 students. The other student goes to the heel of the foot, and then you measure the patient's height. Because a lot of times what happens is when patients are admitted, instead of the height actually being measured, they look at the patient, they estimate, and that's what they type in. And now it's in the medical record, and everything is based off this estimate. So it would be a good research paper for us to print If we could see what's listed in the patient's chart or in the medical record and then measure it ourselves and see if it correlates. So you have to know their height, and then you have to calculate what their ideal body weight should be. Remember, it can't just be their overall weight, because adipose tissue does not change the size of the lungs. The size of the lungs stay the same. And so the formula, my in-text, formula for a male it's probably best to do this backwards. So this is the formula that I gave you. You start with 106 for adults. And then you add 6 times the height minus 60. So you got to figure out the height in inches, subtract 60, multiply by 6, and add 106 to it. So you kind of work the formula backwards. So if we have somebody who is 6 feet tall, how many inches is 6 feet? It's 72 inches. So 72 minus 60 is 12. 12 times 6, 72. So now we have 106 plus 72 equals 178. So the ideal body weight would be 178 pounds. But we need to know kilograms. So we have to take 178, divide by 2.2. And then that's going to give us the kilogram body weight. .9 kilograms. All right, so now that you have the patient's ideal body weight and you have the tidal volume that the patient is being ventilated with, you could take the tidal volume, divide by ideal body weight, and then you're going to see how many mLs per kilogram they're being ventilated with. So the scenario is tidal volume is 400 mLs. How many mLs per kilogram is the patient being ventilated with? So it would be 400. So let me put the formula in. Tidal volume divided by the kilograms ideal body weight. So 400 divided by 80.9. Comes out to 4.9 mLs per kilogram. And then once you have the patient's ideal body weight, you could use that to calculate what tidal volume to set on the ventilator. So it depends on how the test question is asked, what you need to do. So let's say you're told, okay, put this patient on a ventilator. Lung pathology is normal. So we're not worried about ARDS, so we don't need that 4 to 6 mLs per kilogram. So what would be your tidal volume range? Okay, your tidal volume range would be 6 to 8 mLs per kilogram for normal lung pathology. And that'll give you a tidal volume that's acceptable to the lungs and will cause the least amount of barotrauma to the alveoli. And I think that's it for advanced equipment for the day. So I'll put those notes away, clear this. And for pulmonary function lecture. We went through when would you recommend a pulmonary function be done? So during I'm hoping that you listen to the lecture and then listen to the review. But so you should have the reasons why a pulmonary function is performed. I did mention that chemotherapy, radiation therapy is very inflammatory to the body, and it can affect pulmonary function. So before chemo or radiation is done, they'll ask for a baseline PFT. And then after treatment, they'll repeat the PFT. Then we categorized diseases as being restrictive or obstructive. So we mentioned CBABE. Those letters list the obstructive diseases. It's kind of like a mnemonic for remembering. And then I said everything else is restrictive. And then of course we come across a tumor growing into the trachea. Is that restrictive or obstructive? So it is obstructive unless it has completely occluded the airway. And now you've got loss of lung volume distal to that. So at that point, it becomes restrictive. But I think everything else fit into this mnemonic. So looking at cystic fibrosis, bronchitis, chronic bronchitis, asthma, bronchiectasis, when you, instead of having laminar airways, you've got pouches that accumulate mucus, that's your bronchiectasis. Emphysema is another obstructive disease where you have loss of elastic tissue that keeps the airways open, and they tend to collapse on exhalation. So those are all the obstructive diseases. So anything affecting volume is considered restrictive. Anything affecting flow is obstructive. So let me just summarize that real quick. So restrictive is loss of volume and obstructive is decreased airflow. Okay, and then we went through the box. We listed the volumes, and then we listed the capacities. I still recommend that if you're going to answer any questions about capacities, lung volumes, it's best to draw another box, write down your 4 volumes, and then have 2 more columns for your capacities. And then you'll be able to figure out what the correct answer is. Okay, so let me draw a box. Nope. Oh dear. So the first one was total lung capacity. That includes all possible volume in the lungs. And then the next box, you're going to draw your 4 volumes. So you've got your tidal volume, your inspiratory reserve volume. After a normal exhalation, we've got air still left in our lungs. What we can exhale, we call it expiratory reserve volume. And what we can't exhale, no matter how hard we push and struggle and try, it stays in our airways, the residual volume. Okay, then the next 2 boxes are the capacities. Let's see. So if we exhale normally, and then we take in a deep, deep, deep breath of air, as deep as we can, we fill our lungs all the way to capacity. What are we breathing in? We're breathing in our tidal volume, and then we keep breathing in. It's called the inspiratory reserve volume. All of that together is your inspiratory capacity. And then when you exhale, all the volume left in your lungs is called your functional residual capacity, FRC. So when we dial in PEEP on the ventilator, we increase the FRC, kind of helps with oxygenating or keeping the alveoli open. Our oxygenation improves. But what the PEEP does is it increases the FRC a little bit. Okay, and then the third capacity is called vital capacity. When you take in a deep breath as deep as you can and your lungs are at full capacity, and then you blow all of your air out and you blow and blow and blow, you can't get any more air out. You've just exhaled your inspiratory reserve volume. You've exhaled your tidal volume, and you've exhaled your expiratory reserve volume. The only thing left in your lungs is the residual volume. You can't exhale that no matter how hard you try. So that is the vital capacity. And then when you listen to the lecture, it has other questions on there. And we're way over on time, but thanks. I hope this helps you. Have a good day.